Tuberculosis is an infectious disease that is still endemic in many countries. Tuberculosis is caused by the bacteria of the TB complex. Tuberculosis is still the leading killer among infectious diseases around the world. And only in the past 2 years, COVID-19 has caused more death than tuberculosis. But in endemic countries, tuberculosis remains a big killer, causing suffering for people affected and their family. Tuberculosis is transmittable, and people that are affected by the disease can infect the others, and the disease can appear from months to years from the infection. Not everybody develops the disease, but people that are immunocompromised tend to develop the active form of tuberculosis more than people that are immunocompetent. In order to break the circle of transmission, we need to diagnose the disease in a fast and effective way and to provide a proper treatment for the people that have developed that either are infected or have, even worse, developed the active form of the disease. Historically, we use to diagnose TB through smear microscopy on sputum for the respiratory forms that are by large the majority of the cases, and to perform cultures wherever it was possible to do. M. tuberculosis bacteria are in fact pathogens that need to be handled in a particular environment, and the infrastructure to culture the bacteria are not present in all places around the world. Bacteria grow very slowly, so in order to have the diagnosis and the resistant test provided to the clinician for an appropriate treatment, it is a very long time. And most of the time, people used to be started on treatment without sure data on the sensitivity of the bacteria. The reason was also linked to the fact that the majority of cases were treated with a standard 6 months therapy with 4 drugs, and the majority of the cases that are not drug resistant still respond to this therapy. The problem arose when the drug resistant emerged, and drug resistant tuberculosis is becoming a major threat around the world. We are living in an exciting time in terms of drugs for tuberculosis. In fact, previously, drug-resistant tuberculosis needed to be treated with drugs that were very toxic, very challenging for the person affected to be taken. In many cases, injectable regimens were used, and the drugs were causing long time, sometimes permanent side effect. The people needed to be treated for up to 2 years. Many people dropped the treatment because they really couldn't stand the long-term and the immediate side effect. Now, as I said, we are living an exciting time because for the first time we do have new drugs to treat drug-resistant tuberculosis. These new drugs allow us to shorten the treatment time and to alleviate the side effect for the people affected. What is the problem then? The problem is that we were not fast enough to develop the companion diagnostic for those new drugs. So at this time, we do have regimens, but we do not have diagnostics to support the diagnosis of sensitivity of resistance for those forms. People think that being new drugs, there are no resistance still developed around the world. In reality, we know that when we expose bacteria to new drugs, drug resistance tends to develop and develop fast. And despite the fact that for mycobacteria it may not be so fast, but is happening. We know already that for bedaquiline, a new drug that was introduced for the treatment a few years ago, for the treatment of drug-resistant tuberculosis a few years ago, we do have a good 10% resistance among the MDR forms in some countries. And the testing for bedaquiline is still non-available everywhere. So we need to make available the capacity to test all over in the world wherever the new drugs are used. And we also need to work as mycobacteriologists all together to develop new molecular tests for the new drugs. And in order to do that, we really need to put together groups of bioinformatics, mycobacteriologists, clinicians, to understand better what are the relevant genes and the relevant mutations that are associated to the drug resistant to those new drugs. In addition, then, we need to make tests that we are using in Europe and North America, such as the target next generation sequencing and the whole genome sequencing, available all over in the world, and in particular in places where drug-resistant tuberculosis is present with a large amount of cases. We need to make those tests as automated as possible and increase the capacity for the local people to use those tests and to interpret the result. We also need to work on the capacity of the clinicians to interpret the molecular result in order to speed up the correct management of the people affected by drug-resistant tuberculosis. In conclusion, we really need to have on board a young group of mycobacteriologists, bioinformatics, clinicians that collaborate all together in this field in order to increase the chances of success, of therapy success, of the many people affected by tuberculosis, and in particular drug-resistant tuberculosis around the world.